Interview and physical examination secret number 6 is to focus on the neurologic aspect of the examination. Focus on the neurologic aspect of the examination. And the reason that this is so important is because the AMA guides are largely based on neurologic findings. And those of you that are involved in the physical medicines and examining injured workers with musculoskeletal or nervous system disorders, those particular chapters in the AMA guides rely heavily upon neurologic exam findings. So, for example, Chapter 13, the entire nervous system chapter, of course, is exclusively based on neurologic findings. Chapter 15, the spine chapter, which we'll discuss in a moment, relies heavily upon neurologic exam findings. Chapter 16, the upper extremity, has extensive reference to neurologic exam findings. Chapter 17, the lower extremity examination chapter, relies heavily also on neurologic findings. And then Chapter 18, the pain chapter, again relies almost entirely upon neurologic findings for conclusions of permanent impairment related to pain. Now, Chapter 18, the pain chapter, allows for other causes of chronic pain to qualify for permanent impairment, but the large majority of the conditions that are discussed in Chapter 18 are largely neurologic conditions. And so the point is that the AMA guides are basically about neurology. So the secret number 6 is to focus on the neurologic aspect of the examination, and I have to admit that like some of the other procedures that we're discussing in this program, the neurologic examination was not always the focus of my own clinical exam, and I had to adapt my own clinical exam to include more neurologic-based procedures to be consistent with the description of permanent impairments as those are given in the AMA guides. So let's just go through some of the references in the AMA guides that talk about the importance of the neurologic exam, just to highlight and demonstrate the extensive focus that the AMA guides do give to the neurologic portion of the examination. So, of course, Chapter 13 is all about the nervous system. So that goes without saying that a strong knowledge of neurologic exam procedures is required if you are going to be examining injured workers that have central nervous system and peripheral nervous system disorders. So we're not going to go into great length in Chapter 13 because that's pretty much intuitive. But let's talk about Chapter 15. Let's go over some examples in Chapter 15 of the AMA guides that discuss the importance of the neurologic exam and the importance of excellent knowledge of spinal neurology. So here's a reference on page 373 of the AMA guides. It says, quote, "The spine consists of 4 regions, the cervical, thoracic, lumbar, and sacral vertebrae, and associated soft tissues, including muscles, ligaments, discs, and neural components." So there's a specific reference of the importance of the neural components in an examination of the spine. On page 374, also in Chapter 15, it says, quote, "The history must describe in detail the chief complaint and the quality, severity, anatomic location, frequency, and duration of symptoms, including pain, numbness, paresthesias, and weakness," unquote. And all of those are neurologically based symptoms: pain, numbness, paresthesias, and weakness, all neurologic symptoms. Again, on page 374, it talks about the examination of the spine. It says, quote, "Since a targeted neurologic assessment is needed for individuals with back or neck problems, the physician must have a good grasp of basic neurologic examination techniques and principles, including reflexes, muscle strength and atrophy, sensory deficits, root tension signs, gait, and the need for assistive devices." And I created a program that goes through the entire neurologic examination. It's a 2-hour discussion, and it's included in the 6-hour program entitled Medical Legal Report Writing and Technique of the QME Examination. And when I refer to technique of the QME Examination, I'm referring largely to the technique of the neurologic portion of the QME Examination. And in that program, there's extensive discussion specifically on manual muscle testing, one of the neurologic motor examinations. And do you know that even though the AMA guides describe manual muscle testing as a means of testing motor nerves, there is no procedure described in the AMA guides as to how manual muscle testing is to be conducted. And so I did extensive research on that for you, and I created a program and a description of how to conduct manual muscle testing, and it's included in the 6-hour program that I just described. So you'll want to get that program. And also in that program goes through some basic neurology, at least in the depth that it's described in the AMA guides, and gives a good discussion of dermatomes, good discussion of myotomes, and a review about reflex loops and reflex arcs. And so that serves as a great review about some of the basic neurology, at least to the depth that it's described in the AMA guides. Continuing on in chapter 15, just to impress you regarding the importance of the neurologic examination, and on page 375, which is table 15.1, there is a description of different neurologic examination procedures, and it gives you those procedures based on the position of the examinee. There are standing procedures, sitting procedures, procedures while the patient is supine, and procedures when the patient is prone. Talks about lower down on page 375 how to evaluate sciatic nerve tension signs, and page 376 talks about sciatic nerve and femoral nerve stretch tests. And speaking of sciatic nerve tension signs, I want to ask you a question. What are, off the top of your head, what are some of these sciatic nerve tension signs that you rely on in formulating your conclusion that indeed sciatic nerve tension exists? I'll just give you a moment to think about that. There are several, and as described in table 15.1, there are sciatic nerve tension signs that we observe with the patient supine. There are sciatic nerve tension signs that we observe with the examinee sitting. There are sciatic nerve tension signs that we can observe with the examinee standing. And of course, all of those findings should be consistent throughout the positions. And while you may be familiar with supine maneuvers and sitting maneuvers, I note some doctors and even myself forget that sciatic nerve tension can be demonstrated in the standing position. It's known as Neary's bowstring sign. And Neary's bowstring sign, if it's present or absent, could substantiate or refute findings either supine or sitting. So I mentioned that here as a reminder to you to do an excellent sciatic nerve tension exam in all positions and establish for consistency among the positions. Page 376 discusses neurologic tests including reflexes, sensory changes, and motor changes. Pages 377 goes through sensory testing by touch, by pinprick, by light touch, by vibrating fork, and it gives a diagram of the autonomous zones of the specific cervical and lumbar spine nerve roots. And with regards to sensory testing, and relating back to one of the earlier secrets, which encourage you to do every single possible objective test, I recommend that your sensory examination include at least two modalities. At least two modalities, whether that be touch and pinprick, or light touch and joint position sense, or vibrating fork and two-point discrimination. I recommend that you conduct at least two of the different modalities every time you perform your sensory examination. Page 380 of Chapter 15 talks about the neurologic basis for using the range of motion method. Includes multi-level disc herniations, stenosis with radiculopathy, includes recurrent radiculopathy, includes other episodes or other pathologies producing radiculopathy. So, should I repeat this? This is radiculopathy. Again, a neurologic-based finding. And also the DRE methods on page 384. The DRE methods also, if you'll note, if you refer to page 384, are largely focused on neurology, especially the DRE 3 categories with their emphasis on radiculopathy. So Chapter 15 certainly is all about neurology, and so the purpose of this specific examination secret is to encourage you to sharpen your neurologic exam and report your neurologic exam findings thoroughly, accurately, and in great detail in your report. Chapter 16, the upper extremity chapter, also is heavily based upon neurology. Here we're not talking about the spinal nerve roots, in this case the cervical spine nerve roots. Here we're talking about peripheral nerves. But again, an excellent neurologic exam and excellent understanding of upper extremity neurology is required for rendering opinions on permanent impairment under Chapter 16. So let me give you a couple of references from Chapter 16 that discuss the neurologic exam. Specifically, Section 16.3 talks about sensory impairment due to digital nerve lesions. And in this section it talks about some of the specialized receptor organs that we would find in the fingers. Special receptor organs such as Merkel's discs, Meissner's corpuscles, Ruffini endings, free nerve endings, and we go into great discussion of these specialized receptor organs in the 6-hour program that I was mentioning earlier. So if you feel like you need a little touch-up on your neurology, I would recommend that program for you. Section 16.5 talks about peripheral nerve disorders. It states here, quote, accurate diagnosis of peripheral nerve disorders is based on a detailed history, a thorough physical examination with special emphasis on the nervous and vascular systems, and appropriate diagnostic tests, including a variety of electrical and imaging studies. Excellent knowledge of the morphologic anatomy and physiology of the nervous system is a prerequisite. So here the AMA guides are telling us that excellent knowledge of the anatomy and physiology is a prerequisite. So the purpose of this is to encourage you to brush up and tune up a bit on your neurology. Sometimes in clinical practice we get a little rusty on some of the basic anatomy and physiology, and the AMA guides give us an excellent review in the specific chapters, and which is what we're reviewing here now. Further in chapter 16, section 16.5, again about the peripheral nerve disorders, states that it includes both sensory and motor dysfunction. There's a large section in section 16.5 that discusses the brachial plexus, discusses the major peripheral nerves, and then goes on to many different types of conditions, including entrapment and compression neuropathies, and discussion of chronic regional pain syndrome, CRIPS 1 and CRIPS 2. And it talks about the neurology in a progression from the spinal cord to the spinal nerves to the brachial plexus to the peripheral nerves all the way to the digital sensory nerves. So it's all about the neurology. Chapter 17 is also all about the neurology. Chapter 17 is the lower extremity. Specific references from Chapter 17 that deal with neurology includes section 17.2d, which talks about muscle atrophy due to peripheral nerve injury. So therefore, atrophy should be a regular part of the neurologic exam. Section 17.2l regarding the peripheral nerve injuries. Section 17.2l regarding the peripheral nerve injuries talks about sensory and motor dysfunction. And in this section there's a large section that discusses the lumbosacral plexus, the major peripheral nerves, and many different types of neurologic conditions, including chronic regional pain syndrome. Then Chapter 8 has some specific neurology references as well. Table 18.1 specifically talks about various different pain syndromes, including headaches, post-herpetic neuralgia, tic-douloureux, describes any type of generalized injury to the nervous system. And notice that these pain syndromes are all neurologic. And we have an entire program. It's not yet been approved, at least as the date of this recording. It's not yet been approved by the Division of Workers' Compensation. But we have an entire 3-hour program devoted to how to conduct a formal pain impairment analysis. And that is a fascinating program that describes a step-by-step procedure for providing permanent impairment due to the added burden of pain. We touch upon that a little bit more later on in this particular program, but for an extensive discussion of how to do a formal pain-related impairment analysis, I refer you to a different program. Also in Table 18.20, also in Chapter 18, it discusses associated pain syndromes. Again, these are all neurologic conditions. It talks about post-paraplegic pain, talks about brachial plexus avulsion pain, talks about nerve entrapment syndromes, talks about peripheral neuropathy, and some of the nerve entrapment syndromes that are specifically discussed in other chapters of the AMA guides include, for example, thoracic outlet syndrome, cubital tunnel syndrome, carpal tunnel syndrome, handlebar palsy, tarsal tunnel syndrome, and many others. And notice that all of these are neurologic syndromes. Now, neurologic syndromes are not the only pain and associated pain syndromes for which you can provide permanent impairment due to the added burden of pain. In other words, there are other syndromes responsible for pain that qualify for permanent impairment under the Chapter 18. However, the AMA guides themselves, at least under the strict interpretation of the AMA guides, are largely focused on neurologic pain syndromes. So the purpose of this particular discussion that we're having is to encourage you to sharpen your focus on the neurologic portion of the examination. And if you couple this recommendation with an earlier recommendation to perform every single objective test, the take-home message from this section is to make sure that you perform every single objective neurologic exam procedure, including, for example, girth measurements. That requires an objective measurement. Reflexes, that requires an objective measurement. Sensory testing, particularly with two different types of instruments for two modalities, that requires an objective measurement, and etc.